And we should be live right now. So we should have people coming in right now. I'm going to go ahead and share my screen.
Okay.
There we go. Oh, this is awesome. So we'll give everybody a few minutes to come in. Let's see who we've got coming in. Brian Enser and Andrea Carr already in. I see Victor from Mexico coming in. This is great. I want to thank everybody for who's coming to join us for our first of 3 virtual meetups. We're going to give everybody a couple minutes to come on in. If you want to say hello in the chat and introduce yourself, or just, you know, if you have any questions or anything, please feel free to use the chat and we'll be able to answer them. I'm going to go ahead and kind of share a little bit about how this program is going to work. This is our first virtual meeting. It's similar to a webinar format. We have the infamous Dr. Laurence Greenbaum from Emory, who is one of our cystinosis gurus, who's going to be sharing some basics information with you. And we really want to encourage you to ask questions. This is your time to get, you know, really all the information that you need to make good decisions for your health or for your child's health or someone else you love. So I'm going to go ahead and get started. I'd like to introduce it first before we get started with Dr. Greenbaum. Christy Greeley, the Executive Director of the Cystinosis Research Network, as well as Clinton Moore, the President, who are going to share a little bit about the organization and why they have brought us together. Christy and Clinton? Who wants to go first?
I'll go first. Hi, everyone. Christy Greeley, Executive Director and VP of Research. I just want to thank Dr. Greenbaum so much for agreeing to help us out today and give this talk. We really wanted to meet in person this year. We're going to meet all over the country and bring people together, but obviously we're not, like everyone else. And so we thought these were great ways to still get everyone together and still have some information to share with everyone. We'll have connections, and this session and some others will be recorded and available on our website. So Clinton, do you want to take over and give people a little bit of just a summary of CRN and what we do?
You're on mute. Oh, I think he's stuck on mute. There you are.
How about now?
You're perfect.
Can you hear me now?
I can hear you.
You're doing well. You can hear me now?
Yeah, I can hear you now.
Yes.
Like
After like 100 Zoom calls. After like 100 Zoom calls, you think I'd be used to this by now. Anyway, I am Clinton Moore, the President of the CRN. Welcome everybody to this virtual meeting. Unfortunately, we can't meet in person due to COVID, but hopefully this mess will clear up soon, and then we'll be able to get back into our in-person format. The CRN is it's an all-volunteer nonprofit that focuses strictly on cystinosis, and really three main key points. It's research, family support, and development, all led by a great team of people that I have the pleasure of working with. And I think most people's favorite is family support, especially when we have new families coming aboard, like we did today. Just being able to reach out and get them started on a path to success and help them in any way possible. So that's just a very, very, very brief description of what we do. We have adult groups, a lab. We have a lot going on. We're a very busy group of people, but welcome. And Carrie, I'll send it right back to you.
Fantastic. Yeah, to put it mildly, very busy. I mean, the stuff that you guys have accomplished, not only over this last year with kind of the pandemic reshifting everybody's work that, you know, needs to get done. You guys are still making it happen. And just, you know, these meetups themselves are still offering a great way for us to continue to educate our community and bring us all together. So I wanted to share a little bit about this series itself. You know, it's a 3-topic series. We're going to start off tonight with Dr. Greenbaum's going to kick us off talking about the basics of cystinosis. Then next week, we're going to dive a little bit more into the mental health aspect of cystinosis, both as a patient and as a caregiver. For those of you that registered directly for that session, you had the opportunity to ask questions that are going to be presented to our psychologist, Courtney Zimmerman Taylor out of Texas Children's Hospital. And then we're going to wrap up the series on October 14th, focusing on research and gene therapy. There's a lot of great things happening around cystinosis and research, and we're excited to kind of finish off the series talking about the future and hope for the future. Just a few housekeeping things. You know, Dr. Greenbaum and the CRN leadership, they may, share a lot of information about medical information. We don't want to give you medical advice. This is really to help guide your discussions with your healthcare team. So make sure whatever you bring from this meeting, talk to your healthcare team about it. Zoom, as you know, we are using the Zoom platform. It is not HIPAA compliant. So I just want to, kind of make everybody aware of what you share. This is not private. So, I would refrain from sharing personal information like patients' names, age, and specifics, things like that, because you don't want it to get out. And then finally, we are recording this. So if you're in this meeting, we are recording it so it can be viewed by attendees in the future. We did have quite a few people register for this who were unfortunately not available to make it today. So any questions you ask or any comments that you make will be recorded. So that being said, if you have any questions for Dr. Greenbaum during the presentation, there's the chat feature at the bottom. Please feel free at any point during his conversation to put your questions or comments in the chat, and I will relay them to him at the end of the session, or if it pertains to something he's talking about at that time, I will share it with him at that time as well. So that being said, Dr. Greenbaum, I am going to transfer this over to you and let you share your screen, and give me one quick second and you should be able to take it over. So I'm going to stop mine. And are you able to share yours?
Not yet.
Okay.
Now I probably will be. Hopefully it's still disabled.
Oh.
1 second.
It's being temperamental. Now you should be good.
Okay, here we go. All right.
There you go.
Okay.
Perfect. Looks great.
Okay, and I have the chat up. Well, thank you so much. It's really an honor whenever I get to meet with the cystinosis community. I've cared for cystinosis patients my entire career and care for quite a few currently, and I love these opportunities to get together with people and exchange information. I'm hopefully going to provide information that will be useful for all of you, but I inevitably learn things, just like you'll probably learn things from each other, because some of the more practical aspects of caring for a child with a chronic illness, or caring for yourself as an adult with a chronic illness, some of those more practical things I will learn and you'll teach each other. So along with listening to what I say, it's also advisable to listen to what other people say. But again, I want to thank the CRN for organizing this, and Carrie for organizing it. And I'm looking forward to spending the next hour or so with you. I'm a pediatric nephrologist, and I work at Emory University. And there's a picture of, let's see, that's, let me see if I can, there we go. That's my office, actually, on the bridge, suspended in the air at Emory. And then on the right, on the bottom, is our hospital, Children's Healthcare of Atlanta, which is where I take care of patients. So, as was mentioned, I'm more than happy to answer questions along the way through the chat. I'll need to pace it a little bit so we can get through the presentation, but I will try and answer as many questions as I can during the presentation, and certainly after the presentation as well. There's someone has already asked a question about struggling with feeding my baby while this is happening. Do food aversions develop because of forcing medication orally? How early should we consider a G-tube? Is it a good idea to be proactive and get the G-tube now before even trying oral meds? On an 8-month-old Pro-Sysby? And this is someone who is going to be feeding the baby later, so wants to find out about things. G-tubes are very commonly used in children with cystinosis. They have a lot of advantages as a way to give medications, which are often a bit of a struggle because of taste and quantity and tolerance and how often you need to give them. And also some children with cystinosis struggle with getting enough nutrition, struggle with getting enough fluid to meet their high fluid needs. So G-tubes are used quite frequently. In terms of causing food aversions by trying to feed children lots of medicines, that can happen in some kids. It doesn't happen in all kids, and it really is very individualized. If some families are able to get all of the medicines and nutrition and everything in without a G-tube or a nasogastric tube or some sort of tube, but some families struggle with that, and it's not because one family is better at doing it than another. It's simply that it's the degree of difficulty varies from child to child. So I think you really need to sort of see how your child is doing in terms of making that decision. Obviously, some conversations with your physician as well. Are they getting their meds in? Are they getting their nutrition in? Are they getting enough fluid? Is it turning into such a battle that it becomes impossible? So I think you really need to gauge all of those things before making a decision. But certainly putting a G-tube in is not a sign of failure. It can be very effective, very helpful. And so certainly doing that. And then someone mentioned that it was a game changer getting the tube, and mentioning that NG versus G-tube, that the G-tube is the way to go. And I would agree 100% that NG is somewhat viewed as a temporary thing until you can get the G-tube, or to see if if you just need it for a short period of time. But if it's going to be needed for more than a few months, the G-tube is usually what I would suggest. So let's move on to the presentation. So cystinosis is what we call an autosomal recessive disorder. It's a genetic disorder. It's quite rare. 1 in 100,000 to 200,000 people have cystinosis. And it typically presents in infancy with failure to thrive, which just basically means that children aren't growing well, gaining weight well. And they have something called Fanconi syndrome, which we'll be talking about. And without therapy, and now we do have therapy, people develop kidney failure at about age 10 on average. And other manifestations tend to increase with age, especially without therapy. Sorry, when I use the chat. And the problem in cystinosis, in terms of understanding what's going wrong with the body in cystinosis, we have to look at the lysosome. And this is a drawing of a cell. A cell consists of what's called the cytoplasm and the nucleus. The nucleus is kind of the center of the cell, the controlling part of the cell. And in the cytoplasm, there's lots and lots of lysosomes. And the lysosomes exist in 50 to 1,000 in every cell. So lots of lysosomes. And these are little garbage disposal systems. And the main function that they have is degrading molecules. So when molecules are no longer useful in the cell, they degrade them. They have some other functions too, which are listed, but think of them as really garbage disposal areas. And this is a lysosome. So this is that small little lysosome. And proteins, which are sort of one of the building blocks of the body, when they're no longer functioning, no longer useful, they're put into the lysosome and they're broken down into their components, which are amino acids. So proteins are made of lots and lots of amino acids. And one of those amino acids is cysteine. And cysteine is oxidized into cysteine, which is basically 2 cysteine molecules. And normally, once you've broken the protein down, the cysteine needs to leave the lysosome and go back and be recycled. So the two cysteines come together, they merge together, and then they leave through this molecule that you'll hear about called cystinosin. And the cysteine in the cytoplasm is then broken apart again into the two cysteines. And two things can happen. It can be used to make new proteins. It's an amino acid, or it can be degraded and processed into its fundamental parts and used in other ways by the cell. That's what happens if things are working well. In cystinosis, you form the cysteine, but there's no cystinosin. That transporter that allows the cysteine to get out of the lysosome is not functional. And that's the genetic defect in cystinosis. And that cysteine can't get out, and it builds up in the lysosome, and you get more and more cysteine. And cysteine is not very soluble, I mean, it doesn't dissolve well. So if there's enough cysteine around, it forms crystals, and these crystals poison the lysosome and poison the cells and cause the manifestations of cystinosis. And then you end up with these crystals. These are cystine crystals in the cell, and you can see them there. They're not supposed to be there, and you can imagine if your cells have these big crystals in them, they may not function normally. All right. And these are pictures of cystine crystals in the liver, cystine crystals in the kidney. You really form cystine crystals everywhere. And it's just a matter of what organ do they affect earliest, which happens to be the kidney, and what effects do they have on other organs, and that determines what the symptoms of cystinosis are. And again, the earliest symptoms are in the kidney because the kidney is very sensitive to building up cysteine inside its cells. All right, so the genetics of cystinosis, I mentioned that it's a autosomal recessive disease, and it's due to mutations in a gene called CTNS, and that's a gene that codes for this protein called cystinosin, and it's this transporter in the lysosome, and it takes cysteine out of the lysosomes. And there's lots of different mutations in this gene that can be present, but there's one mutation that's extremely common in people of European heritage, and that's this very large deletion. It's a 57 kilobase deletion. It's a large chunk of DNA that's missing. And so it's kind of easy to see if you're looking for it. And about 3/4 of people with cystinosis who are of European descent have this mutation on at least on one of their genes that's defective. And it turns out that if you have this deletion, you're also missing another protein nearby that makes you less sensitive to hot chili peppers. So people with cystinosis can tolerate very hot food if they have two mutations of this very large type. So not all patients with cystinosis, but some patients can tolerate very hot food, hot spicy foods without having a problem. So I guess that's a benefit. In an autosomal recessive disorder, you inherit one gene from your mother and one gene from your father. And in cystinosis, the father has one normal gene and one abnormal gene. And as long as you have one normal gene, you're absolutely fine. You're not affected. And the mother has one normal gene and one abnormal gene, and she's also unaffected. But the children of these two parents, they have about a 25% chance of having a child with cystinosis. And that child has inherited both abnormal genes. Now, half of the children on average will have inherited one bad gene, so they would be carriers. And 1 out of 4 children will have inherited nothing but normal genes, so they will not be carriers. And again, the carriers are unaffected. If you have other children that may be carriers, they would only have a child with cystinosis if they have a if they have a partner who also is a carrier, and they are having a child that has the two abnormal genes. So cystinosis doesn't tend to pass down in families from generation to generation. It tends to affect one generation, the children of one parent, of one father and one mother, who each of those children has a 25% chance of having the disease. Of course, 25% is just like, if you go to Las Vegas and bet on red, you could bet on red 4 times in a row, and you may get red 4 times in a row, or you may get black 4 times in a row. So you could have your first 3 children could have cystinosis, or you could have 10 children, and then your 11th child could have cystinosis. And it's just a matter of how the coin flips, but it's a 25% risk. Okay. There are 3 clinical variants of cystinosis. Far and away, most of you are dealing with what we call the nephropathic infantile form, which is greater than 95% of patients with cystinosis. And this is the form that tends to present during infancy. It's the most severe form of the disease, and it's what most people who have cystinosis have. There's what's called a nephropathic juvenile form, and that's a disease that shows up a little bit later than in life and progresses slower. So it's sort of a less aggressive form of the disease, but it's pretty similar to the more common nephropathic form. It just shows up later and tends to have manifestations later. And then there's a third type, it's called the ocular form, where the only problem you have is the cystine crystals depositing in the eye. So you have none of the other features of cystinosis. And that's a very, very mild form, obviously. And that's often diagnosed in adulthood when, someone goes to see the eye doctor and they see these funny crystals, and they ultimately figure out where they're from. They're all due to mutations in that same gene, but the more common form, the mutation makes the gene completely non-functional, and the less severe forms, at least one of the genes has a little bit of function, and that makes the disease less severe. Any questions so far? I've gone through a lot of what I call physiology. That's how things work and what's going wrong.
Please just throw them in the chat, and Dr. Greenbaum can answer them.
All right. Well,
actually, I do have a question for you that I remember at a patient meeting regarding back to the family planning, the genetics of it. It was a sister of a cystinosis patient who was looking to get pregnant. She wanted to know, and I don't remember the response was, she wanted to know if she should look into kind of genetic counseling, or if her and her partner should get tested, because she was a carrier and she didn't know about her potential husband.
Yeah, so that's a good question. There'd be nothing wrong with doing that and getting that advice. The chances, though, of the partner being a carrier, unless there's some sort of family history on the partner's side, is extraordinarily low. So it wouldn't be something that we would routinely recommend that be done, because the risks in the risk that the partner is a carrier is very, very low, because it's just such a rare gene defect. So it's not something that's routinely done. If you're very concerned and you wanted to do it, certainly it can be done. And now that genetic testing is a lot less expensive and easier to be done, it might be able to be done. But genetic testing used to cost thousands and thousands of dollars. So not only was it, and a lot of insurance companies don't like to pay for it, and so not only was it probably not necessary, it was also a very expensive thing to do.
Wonderful. I think that's good information for those who are thinking about it. Thank you.
Sure. So the initial symptoms, you all probably know this better than me, failure to thrive, so again, not growing well. Infants with cystinosis tend to have what we call polyuria, drinking too much, peeing too much, and polydipsia, drinking too much. And here, you know, it's a chicken or the egg. You can pee too much because you drink too much. You can drink too much because you pee too much. In cystinosis, it's because you pee too much. So you pee so much that you feel dehydrated, so you drink a lot. So the drinking is normal, a normal response to peeing a lot. And one lesson here is you don't want to limit someone with cystinosis from drinking because you think they're peeing a lot because they're drinking so much, because that's not the case. They're drinking a lot because they are peeing a lot. They often have poor appetite, partially because they're spending most of their time drinking. Vomiting is very common. Rickets, which is basically deformities of the bone, are very common. And episodes of dehydration are very common because of peeing so much. You can imagine if you pee a lot and then you get some sort of illness that makes you have vomiting and you can no longer drink a lot, you'll get dehydrated extraordinarily fast. And lots of kids with cystinosis end up being admitted to hospitals multiple times for dehydration until they're finally diagnosed with cystinosis. All right. I don't see any questions in the chat, so I'll just keep moving forward. And this is a picture of a child with very severe rickets. You can see the bone deformities. And then if you were to look at an X-ray, on the left here, you've got a nice normal X-ray, and you can see the bones of the wrists are very flat and smooth. While here in someone with rickets, they're all frayed and they have what we call cupping and very abnormal looking. So you end up with the bones sort of sticking out and you get these widening of the wrists and a variety of other deformities due to rickets. And we'll talk about why that occurs. All right. Diagnosis. How do kids get diagnosed? Well, you can look in their eyes, especially if they're more than 1 to 1.5 years of age, and you'll see these crystals in their cornea. Usually you need an ophthalmologist to do that with a Slit-Lamp. And there's nothing else that causes crystals that look like that. So if you see those crystals, you know what you're doing, you can say that patient has cystinosis. There's no other disease that causes crystals like cystinosis. Or you can measure cystine levels in white blood cells. If you have cystinosis, you're what we call homozygotes. You'll have very elevated white blood cell cystine levels. If you're a carrier, your levels will be less than 1. If you don't have any bad genes, your levels will be less than 0.2. So people who are carriers have a slight increased level, but it doesn't cause any manifestations. You can do genetic testing to make the diagnosis. And nowadays you can do prenatal diagnosis through amniocentesis or chorionic villus sampling, so that's possible. And again, of course, that would only be done typically if there's a family history, there's a sibling who has it, and you want to know whether the fetus has it as well. And this is what the eyes look like. This is on the top here. You can see someone who's got cystinosis, and you can see these crystals. And here's someone who's normal who doesn't. And this is a more dramatic picture. You see these crystals here, and you can tell if you let those crystals build up why it can have an effect on the eye, and why people will often describe them as feeling sandpapery when they get very, very bad. Someone has a question. You said not to limit water. Shouldn't I limit water for my child so he'll drink his formula? When I said fluid or water, I was really talking about access to any sort of liquid. Certainly, you want to make sure that before the children are taking water, you certainly want to try and get the formula into them first. But many children with cystinosis will need more than their usual intake of formula. They'll also need some water on top of it, because the water in the formula will not be enough to keep them hydrated. But certainly getting the nutrition in first is definitely the priority. So that was a great question. All right, and now we're going to do a little bit more physiology, and this is the what's called the nephron, which is there's about 1 million of these in every kidney, and this is where the urine is made. And the nephron consists of a little filter called the glomerulus, and you get water and other things that are in the blood leaving the glomerulus and going through this plumbing system, and ultimately coming out into the bladder and forming urine. But amazingly, what happens is we filter an adult filters about 144 liters a day of fluid through their kidneys, and 143 of those liters are taken back into the body, so are reabsorbed all along these tubules, and you make about 1 liter of urine a day. And so you can imagine if you, instead of reabsorbing 143 liters, you only reabsorb 140 liters, suddenly instead of making 1 liter of urine a day, you'll make 4 liters of urine a day, which is a tremendous amount of urine, and why patients with cystinosis have so much problems with peeing a lot. So now we're going to look at where the defect is in the kidney, what's causing all of this loss of fluids and electrolytes. It's in the proximal tubule, the first part of the nephron right here. And now let's break that down. This is the center of the tubule, this pipe that goes from the filter down and eventually comes out and produces your urine. And these are cells that are lining this filter, and they normally have the job of reabsorbing a lot of what gets filtered in the glomerulus, and so it doesn't end up in your urine. And it turns out the proximal tubule is where a lot of the good things that are filtered in the glomerulus are reabsorbed and taken back into the body, because if you lose them in the urine, it's not very good for you, as you all know, because that's what happens in cystinosis. So what things are reabsorbed in the proximal tubule? Well, one of the main things is something called bicarbonate, which is a base, and it's reabsorbed into the tubule cells, and it ultimately goes back into the blood and goes back into the body. And so it doesn't end up in the urine. And then you have other things that are reabsorbed, such as uric acid, glucose, amino acids, and then a very important molecule or substance called phosphorus. And phosphorus is reabsorbed into the proximal tubule, just like the bicarb. All of these things are reabsorbed. That's what should be happening in your proximal tubule. If that doesn't happen, that's what we call Fanconi syndrome. So it's a proximal tubule that stops working properly. Basically, instead of reabsorbing, you've got these locks preventing reabsorbing from happening. These reabsorbing function is blocked. It's being poisoned by all of those cystine crystals in the cells of the proximal tubule. And so instead of reabsorbing bicarb, it ends up passing through the proximal tubule, and it ends up in the urine of the patient with cystinosis. So you lose lots of sodium, you lose lots of bicarb. You also lose lots of amino acids, lots of uric acid, glucose, and very importantly, phosphorus. And some of these things that...
Sorry, a question did come in directly through the Q&A, and I just wanted to share since we had just talked about it. Do those with a diagnosis have any differences in the way they perspire? Dehydration management is key, but I have heard some anecdotal evidence to say that the way this aggregate produces saliva and the amount of perspiration is less and/or muted. In your practice, have you seen this, or are you familiar with this?
Yeah, we definitely, it definitely seems to be an issue with perspiration, it definitely seems to increase the risk of these children getting overheated and having issues. So it is something that we see. Some families, some children report it more than others, but there is an alteration in the perspiration.
Awesome. Thank you.
All right. Very good. So Fanconi syndrome, what happens is you lose all this bicarb in your urine and you develop a metabolic acidosis, which means you have too much acid in your blood. And too much acid in your blood is bad for you. It makes you not grow, it's bad for your bones, and it's bad for your general metabolism. We see loss of phosphate in the urine. And if you lose lots of phosphate, your serum phosphorus is low. We call that hypophosphatemia, low serum phosphorus. And if you don't have enough phosphorus in your blood, you don't have enough phosphorus to make your bones develop properly, because your bones are basically made of calcium and phosphate. And so if your serum phosphate is low, your bones don't grow well, your bones don't develop properly, and that is what causes the rickets that I showed you earlier, the soft bones, the bad bones, the non-growing bones, and that also contributes to children not growing well. You also end up with glucose in your urine because you're supposed to be reabsorbing glucose in the proximal tubule. So that means that if you show up at the doctor's office and they check your urine and they see sugar in it, they'll think you have diabetes, but it's not diabetes. It's just the kidneys spilling glucose. In diabetes, it's because your serum glucose level is so high, it overwhelms the kidneys. But in Fanconi syndrome, it's not because of diabetes, it's because you're leaking glucose. It doesn't really have a lot of ill effect, but it's helpful for diagnosis, and it can also confuse people about what's going on. You've got a patient who's got glucose in the urine and peeing a lot, people will assume they have diabetes. You'll have a low serum uric acid level. Again, it's helpful diagnostically. It doesn't cause a lot of harm. You'll have lots of amino acids in your urine. Again, it doesn't seem to cause a lot of harm. It's not something that we treat, but it's helpful diagnostically. And then you'll have carnitine loss, and that may cause low carnitine levels. And when we talk about, treating that is something that is debated, whether that's important or necessary. And then along with losing bicarb and phosphorus and glucose, you also lose lots of water, you lose lots of sodium, and you lose lots of potassium. And those all contribute to dehydration, and low potassium can cause low serum potassium, which can cause muscle weakness and other issues. All right. I don't see any more questions in the chat. So we'll keep going. So the treatment of Fanconi syndrome, for the acidosis, you give base to neutralize the acid. So if a child is unable to take pills, they take liquids, medicines called Bicitra or Polycitra or Polycitra K. Occasionally we use liquid sodium bicarbonate. And then there's pills of sodium bicarbonate and pills of potassium citrate. Those are all medicines that are used to treat the acidosis. And then to treat the low phosphorus level, the hypophosphatemia, we give phosphorus supplementation. The challenge with that is it often needs to be given 3 or 4 times a day, so it's kind of inconvenient. And then we give a medicine called calcitriol with the phosphorus, and that's a special form of vitamin D, but that's often necessary to make sure the calcium doesn't get too low and to also help with the absorption of the phosphorus. Any questions? And any questions, you can put them in the chat. The treatment of the polyuria, so peeing a lot, giving the children access to fluid. Again, sometimes putting a tube in to enable the child to get the fluid they need quickly and easily, often with a pump at night so they can get fluid at night while they're sleeping. And then some patients are treated with a type of medicine called a NSAID, a non-steroidal anti-inflammatory drug. The most common NSAID in the world is just plain old ibuprofen, So, Advil or Motrin. There's a sort of a different form of an NSAID that's often used in treating patients with cystinosis called indomethacin. And it seems to be a little bit better than your typical NSAID for treating that high urine output, although you could conceivably just use plain old ibuprofen. Now, this is controversial because NSAIDs can be hard on your kidneys, especially if you're dehydrated. And so one has to sort of weigh the benefits of decreasing the urine output versus the potential side effects on the kidney. And so that's really kind of individualized based on the child, based on understanding these risks and benefits of using that therapy. We often give lots of sodium supplements and potassium supplements. The sodium supplements may come with the base, so that would be the sodium citrate, the Bicitra, the sodium bicarbonate, or it may just come as plain old sodium, so sodium chloride, which is basically salt. And one thing you can, people with cystinosis don't have to be on a low salt diet in general. And in fact, they often have what we call salt craving. They love salty foods, and there's no reason to discourage them from eating salty foods because might as well eat the salt and enjoy it rather than have to take it as a pill. And then a lot of patients need potassium supplements, often as a base, so the potassium citrate, the polycitra K, or just as plain old potassium chloride. And then other medications, carnitine supplementation is controversial. It's not clear whether it's needed or beneficial, and some people use it and some people don't. Calcium supplementation is often necessary. Magnesium supplementation is sometimes necessary. We talked about indomethacin, especially in the first few years of life, sometimes used. And some patients have been treated with ACE inhibitors. These are medicines that decrease protein in the urine. They're usually used to treat high blood pressure, so they will lower your blood pressure. And the reason for using them is to keep the kidneys healthier longer. Whether that really works in cystinosis is not clear. And there's a definite risk of causing decreased kidney function because an ACE inhibitor in someone who's dehydrated and has low blood pressure can cause you to have an episode of acute kidney injury or temporary kidney failure. So if they're used, they have to be used very cautiously. We never give both an ACE inhibitor and indomethacin to the same patient. And if someone's dehydrated, they need to know to stop their ACE inhibitor and indomethacin. So if you have a patient with cystinosis and they're on indomethacin and suddenly they start vomiting, you definitely would want to stop the indomethacin until their vomiting is better and until they're rehydrated. And the same would go for an ACE inhibitor. All right, there's another question in the chat. My baby has high vitamin D. Is that strange given this condition? That's not something that we would expect in cystinosis. There's no reason to have a high level. When you say, just to clarify for people, I talked about that special vitamin D that we sometimes give, the Rocaltrol. That form of vitamin D isn't the type of vitamin D that one usually measures in the blood. That's a different form. The type of vitamin D that one measures in the blood, you typically get from multivitamins. You get it from taking formula that's supplemented with vitamin D. You take it from milk that's supplemented with vitamin D. And there's very few foods that are naturally high in vitamin D. So, and high is sort of a relative term. A child who is on formula and then also taking a vitamin supplement, maybe getting a fair amount of vitamin D, so they could have a, high level, but it'd be pretty unusual to get a toxic level or a harmful level of vitamin D unless one took very high doses. But there's nothing about cystinosis that makes the vitamin D levels high. So it would have to be due to relatively high intake. And then someone asks, is ACE inhibitors and allopril, does it help with microalbumin in the urine? Yeah, that's the concept that ACE inhibitors, enalapril, lisinopril, ramipril, anything that ends with pril is an ACE inhibitor, captopril. They're supposed to reduce protein in the urine, and the protein that we're most concerned about is albumin in the urine, and they will reduce that. It's used to treat a lot of diseases that cause too much albumin in the urine or too much protein in the urine, such as diabetes, for example. The question in cystinosis is we don't know if an ACE inhibitor has the same benefits in cystinosis as it does in a disease like diabetes, where we know that the problem is at the glomerulus and where they're spilling mostly albumin. In cystinosis, they're spilling albumin, but they're also spilling other proteins, amino acids, and whether an ACE inhibitor really changes how the patient does is not completely clear. The only harm is, again, this risk of if the patient becomes dehydrated when they're on it, it can cause their kidney function to temporarily get worse. And that's not good for the kidneys either. So, it's just a real question about whether that's, is the risk worth the benefits? Because we really don't know the benefits, but there may be some. And so if a patient is tolerating it and seems to be doing well on it, some people will take that. Clinical manifestations of cystinosis, we talked about the kidney, Fanconi syndrome in infancy, that tremendous loss of all those good things in the urine. Kidney failure, end-stage renal disease, basically kidney failure, again, by age 10 without therapy. Of course, nowadays, with therapy, that can be delayed. We know that people, non-Hispanic Caucasian children with cystinosis tend to have very blonde hair, but not necessarily in other races or ethnicities. I have African-American patients, Hispanic patients who don't have the blonde hair. In the eyes, you get these corneal crystals, which will cause something called photophobia, meaning that light will be very uncomfortable for people. When you have lots of these crystals, you'll have pain and tears from the light. You often have this rough sensation, patients describe it, when blinking, if it's severe. There are a variety of endocrine problems. You can have muscle weakness, and without treatment over many decades, it can affect the brain. Fortunately, with treatment nowadays, we don't seem to see that. And this is an example of the muscle wasting that one can get in an adult who hadn't been treated, loss of muscles there. You can see especially this gap here without muscles in between the bones of the hand as well. Treatment, kidney failure. There's really only one treatment there's two treatments for kidney failure. You either go on dialysis or you get a transplant. Fortunately, parents can donate to their children because the carrier kidneys are normal. So having the parents of children with cystinosis can donate their kidneys just like any parent can if they're a match and are otherwise healthy. The disease does not come back in the new kidneys. So the new kidneys remain normal. They don't develop Fanconi syndrome. You'll occasionally, if you were to do a biopsy of that transplanted kidney and look, you may see a few crystals, but those are actually crystals of white blood cells that are in the kidney, and they don't cause any problems. But it only cures the kidney disease. It doesn't cure the other manifestations of cystinosis, so you still need to take your cysteamine. All right. What about the new form of eye drops? I'm going to talk about eye drops a little bit later on, so why don't I just defer that if you don't mind, since I'm going to cover that whole topic. But there are new eye drops, which is really exciting. So growth is a big problem in cystinosis. I mentioned that children don't tend to grow well, and so they present being very, very short. And then we're trying to get them to catch up. One thing we can do is give them better nutrition often through a feeding tube. We also correct the acidosis. We correct the rickets with medicines. That helps them grow. The treatment for cystinosis, cysteamine, which we'll be talking about a little bit later, also seems to help them grow. But many patients with cystinosis, in order to really catch up, because they're so far behind, they need to receive growth hormone, or they choose to receive growth hormone. And this is an example of a boy that came to see me from another state. I met him here, and this is a normal growth curve. So normally, you know, when you're 3 years old, you should be this tall, and when you're 18 years old, you should be this tall. And his parents were relatively tall, so he should have been about 6 feet tall based on his mom's height and his dad's height. And here he was heading towards being about 5 feet tall. And he didn't want to be 5 feet tall. We actually, we got him some orthopedic surgery to fix his legs. And then we started him on growth hormone right here. Oops. And you can see that he went from being very short to growing, growing, growing. And there's bad news. He's now taller than me. So I created a monster. But he's very happy off at college, in the middle of the growth curve, and doing well. The eyes. The crystals in the eyes cause this photophobia, which is extremely annoying and bothersome. It means that kids with cystinosis sometimes need to wear sunglasses inside just because of fluorescent light. It means certainly outside they have it makes it very difficult on a sunny day, and it really has a negative effect on the quality of life. But it's not just photophobia, this reaction to light. Long term, without therapy, patients with cystinosis can develop a variety of other manifestations of the disease in the eye, from corneal erosions to glaucoma to damage to the retina and to the optic nerve. But with therapy, both systemic therapy and the drops, those can all be prevented. The drops. So the oral cysteamine treats everything but the eyes. The oral cysteamine doesn't treat the corneal crystals. And so you have to use cysteamine eye drops. And until recently, there was only one brand of cysteamine eye drops available in the United States, and that was a brand called Cysterin. And per the label, you're supposed to use a drop every hour when awake. In reality, we just encourage our patients to use as many drops as possible. And you don't really, if you're using those, you don't have to give them hourly. If you can get, close to 10 drops in a day, but even giving them every 15 to 20 minutes can work. So for example, if at 7 o'clock you do a drop, and at 7:15 you do a drop, and 7:30, 7:45, and 8 o'clock, you can get 5 drops in an hour and not have to be constantly doing it all day long, every hour. But there's a new drop in town called Cystidrops. These drops have been available in Europe for quite a few years. They've been available in Canada, but they weren't available in the United States until a couple of weeks ago. And these are a more viscous drop, so they have a longer staying power. So only you have to use them 4 times a day. So that's the big advantage of these new drops. And a patient that I've been following for about 25 years emailed me about 2 weeks before the FDA approved them and said, when those drops are approved, I want them. And so he was my first prescription for the drops. And they've got a website, of course, where you can learn more about it. All right. I'm having trouble with my child taking eye drops consistently. How much time between drops would start to cause permanent damage? This is from a family not able to attend. So when you say how much time between drops, the goal with drops is to get as many in as you can. It's very challenging in young children to get certainly the 10 drops a day that were recommended with cysteine. Even 4 drops a day can be challenging. You want to get in as many drops as you can. You know, many infants and young children don't get very many drops. They'll have a fair amount of crystals in their eye. They will often eventually develop photophobia. But once they're old enough to be able to tolerate the drops can make the crystals that are there dissolve and go away. And so, I mean, my advice really is, you know, do the best you can. And, you know, in general, we don't see bad things happening for patients that, you know, didn't get drops consistently for those first few years of life. But, you know, you want to do the best you can and try and use them. How do infants do with such a viscous eye drop? Do they tolerate it? Well, I don't think it's very different from the liquid eye drop. You need to put it in, instead of dropping it on the eye, you sort of put it right there in that spot there. And, you know, when they blink, it gets spread around. There's really nothing all that different about doing it. It's one, you know, it's one of the good reasons to go see an ophthalmologist on a regular basis, because they're very good at, you know, guiding you through giving the drops and how to give them and all of those tricks that they know so well, because they have many patients that need to receive drops at all sorts of ages. And so the Cysta drops should be, you know, just as tolerable as the cysteine. It's really just a matter, the nice thing is you don't have to give them as often. But the European experience has been very, very favorable. All right. And then, of course, you've got your sunglasses if you're not able to use the drops as much as you'd like. Other manifestations, I mentioned the endocrine system is affected. The thyroid is usually the first organ to be affected after the kidneys. So you develop what's called hypothyroidism, which means your thyroid doesn't work. So you then give thyroid replacement. Diabetes, real diabetes, can develop in patients with cystinosis, most commonly after transplant, and even patients without cystinosis will sometimes develop diabetes after transplant as a side effect of medications. I mean, it's not a common thing, but it can happen. And cystinosis patients may be a bit more vulnerable to it. So if you have diabetes, you use insulin. We've talked about growth hormone. It's not that they're not making growth hormone, it's that they need more growth hormone than normal to optimize growth. And then androgens, some teenagers and men will use androgen replacement for decreased androgens. Those are male sex hormones. Respiratory problems can develop typically in adults because of muscle weakness of the diaphragm and the other muscles that help the lungs go in and out. And so some patients with cystinosis need to use something called CPAP at night to help with their breathing. So I really advise my older teenagers and my adult patients to be seen and evaluated by a lung specialist, to have pulmonary function testing done, and you know, just keep an eye on that. With therapy, that tends not to develop, but especially in patients who've missed therapy for a prolonged period of time, for one reason or another, that muscle weakness can develop. And I've seen for some of my adult patients where CPAP has transformed their lives because they were not sleeping well at night, not getting enough oxygen at night, they were tired, they were weak, and then once they were on CPAP, they felt a whole lot better. Swallowing problems can develop, and so that's something that, again, more in adults, and so we're always asking about that, and occasionally patients are being evaluated for that. And again, with good therapy, hopefully that will not develop. And then what would you recommend to check for diabetes? A1C. You know, in general, we're not constantly looking for diabetes. Again, it's pretty unusual in childhood, except rarely post-transplant. And typically we're going to see that by an elevated blood sugar level. And if we're seeing elevated blood sugar levels, then we would check an A1C. But we're always checking serum glucose levels on our patients with cystinosis, just because it's part of the panel that we check. And so we're seeing if those blood glucose levels are elevated. So that's typically our basic screening test. If you have a suspicion, certainly getting an A1C would be a reasonable thing to do. And then I was just going to go over how cysteamine works. The cysteamine is the, really the magical treatment for this disease at this point. And cysteamine is this molecule. And remember the lysosome? This is the lysosome. Remember, two cysteines combine to form a cysteine. And we're missing our cystinosin, our protein that normally allows cysteine to escape. And what happens is cysteamine goes into the lysosome. It breaks apart the cysteine into the two component amino acids, and it takes the cysteine out of the cell through another transporter called the lysine transporter, and therefore prevents the cysteine from building up in the lysosome, prevents that crystallization, prevents that poisoning of cells. So that's how cysteamine works. And the cysteamine is actually recycled and takes some more cysteine out. Unfortunately, it doesn't last very long, so you have to take it fairly frequently, as most of you know. And the results are really quite spectacular. It delays renal failure, it improves growth. You need to use the drops for the corneal crystals. Unfortunately, it has lots of nasty side effects. It causes nausea, it causes vomiting, causes a foul taste and smell. There is two forms of cysteamine. There's what we call an immediate release form, the older form called Cystagon, and that's given every 6 hours. And that can be challenging to do that, to take a medicine every 6 hours round the clock. And because of that, a new form of cysteamine was developed called Procysbi, which is a delayed release form. So you only have to take it once every 12 hours. Does cysteamine only prevent crystals, or can it reverse it? Well, it certainly takes the crystals out of the eye, and also is, over time, you recycle your cells and your lysosomes. So, you can definitely decrease the crystal burden in the body as well as in the eyes with cysteamine therapy. So to monitor cysteamine therapy, the oral cysteamine, you measure what we call white blood cell cysteine levels. Those are the levels of cysteine in your white blood cells. With therapy, they should decrease. The place where many of us do the testing is at the University of California, San Diego, so UCSD. They've been doing it for decades. And they used to use something called mixed leukocytes, which is one type of white cell. And there the normal level is less than 1. But a few years ago, they switched to a new assay, which is done in granulocytes, where the normal level is less than 1.9. Baylor also offers the testing. You want to do these tests. You want to check it when the level of the drug is at its lowest. So you want to measure the white blood cell cysteine right before the patient takes their next dose. So if they're on the every 6 hour dosing, you measure it when they're due for their next dose, but before they take it. And if they're on the every 12 hour dosing, you do the same thing about 12 hours after the last dose. Ongoing monitoring, initially you monitor them very often as you're increasing the dose, and you usually increase the dose slowly over time because cysteamine is kind of as I said, a nasty medicine, and patients will often not tolerate it, so you have to slowly go up on the dose. And eventually, once patients are stable, you can measure levels anywhere from every 3 to every 6 months. Some practical information, cysteamine creates an odor. People have tried a variety of things to decrease the odor. Some people report riboflavin or vitamin B2 helps. Some people report chlorophyll helps. We don't have any evidence for either of those, but that's what some people report. If someone has a transplant, they can typically restart cysteamine therapy a few days afterwards once everything else is working well. The Procysbe, you have to be careful about not taking it with food. You can take a small amount of food, especially something like applesauce or citrus fruits. You want to avoid dairy. And if you need to for your lifestyle, timing of meals, school, etc., you can adjust the Q12-hour dosing by an hour. So, if taking it at 7 in the morning and 6 at night works better than 7 and 7 for your family, then that's certainly okay. You can give it with most medicines except for sodium bicarbonate or calcium carbonate. It comes in capsules, and so you can either swallow the capsules or you can open the capsules and put them in your mouth and swallow them but not chew them. You can suspend them in applesauce or jelly. You can suspend them in fruit juice, and you can suspend them in applesauce and squirt them through a G-tube. And there's a very nice website on the Procysbe, a very nice video on the Procysbe website that teaches you how to do that. All right.
Dr. Greenbaum, we did get a question come in, if you don't mind.
Sure.
It's from Victor. Would you explain difference between cystine levels and biomarkers who are supposed to check how cysteamine works in the body?
Can you just repeat that again?
Sure. Would you explain the difference between cystine levels versus biomarkers that are supposed to check how cysteamine is working in the body?
Sure. So that's a pretty sophisticated question. The bottom line for any therapy is how well is it working? Is it doing what it's supposed to be doing? For cysteamine, over the years, it's been found that if you can get the white blood cell levels of cystine into the target range, that seems to be effective, that patients seem to do well. But the reality is, all you're measuring is the levels in white cells. You don't know what the levels are in the kidney or in the liver or in the thyroid or all the other organs of the body. We don't have a good way of measuring that. So it would be great if we had a way of measuring something that told us, is the therapy really working? And we often call those biomarkers. And biomarker basically just means something that tells us what's going on. And it's something in the blood that tells us what's going on. So for example, one biomarker is creatinine. Many of you probably heard of that. Creatinine is a biomarker that tells us how well the kidneys work. It's a great biomarker. It's very accurate at telling us how well the kidneys work. It'd be great if we had a biomarker for cystinosis patients that told us how well the cysteamine is working. Is it really helping the kidneys as much as we think it is when your white blood cell cystine level is at X? And so is there something that we can measure in the blood that would tell us that? Unfortunately, we don't have a biomarker yet for cystinosis that tells us that. So we don't have something else we can measure. But scientists are looking for those sorts of things. They're looking for substances that are in the body that you can just measure, and they tell you what's happening. How well is your kidney working? How well is your therapy working? That's what a biomarker is. All right. So the future for you as a patient, for your children as patients, cysteamine is critical. It has so many positive effects on the short-term and long-term consequences of having cystinosis. So it is clearly the critical therapy currently. Stay healthy. Amazingly, even patients with cystinosis can get overweight. So, try to maintain a healthy weight, because being overweight puts stress on your body. Get exercise. I mentioned that muscle weakness is potential manifestations of cystinosis. And exercise can help maintain your strength. So, get cardiovascular exercise, think about strength training, stay healthy. You don't have to go crazy, but don't become a couch potato. Remember, it's not just the kidney. So a kidney transplant does not fix the disease. So even if you have a kidney transplant, you still need to take your cysteamine, and you still need to monitor your other organs. And that's true whether you've got a functioning kidney or not. It's very important that you don't just worry about the kidney, but you worry about your thyroid, you worry about your muscles, you worry about your lungs. Make sure all of those things are doing well. And the exciting thing is medical advances are coming. Some of you may know that they're doing the first stem cell transplants for patients with cystinosis. They've done 2 so far. A third one is in process, and more are being planned. And this potentially could be transformational for the disease. Obviously, we need to see if it really works. We don't know if it really works yet. We don't have those results, but it's the first step, and it's an exciting first step, and we'll just have to wait and see. But lots of research is being done. Lots of people are working on finding cures for this disease, and stem cell transplant is a potential cure. And that's it. This is from our research unit when we did the studies on ProCysB quite a few years ago now. And at this point, I'd be happy to answer any questions. And I see there's, I think Carrie has summarized some questions that we received before the meeting.
Yeah.
So are there exercise limitations for adults with cystinosis? No. I, like a lot of people who may have some chronic diseases, you need to do what you can tolerate. If someone has muscle weakness, you can do what you can do, but there's no reason to limit exercise unless, your physician says for some reason. But in general, you can do what you can do. You need to be a little bit careful of avoiding becoming overheated. You have to be very careful about not becoming dehydrated, to take plenty of fluid. But you can exercise. Another question: which healthcare specialist would make up a pediatric, quote, dream team for my child's care? I've talked about the fact that cystinosis can affect many different organs in the body. Now some of these tend to occur later on. So I mentioned I send all my older teenagers and adults to see a lung specialist, but younger children, that's really not necessary unless something comes up. And for, especially at a younger age, there tends to be fewer issues, and it somewhat depends on what your nephrologist, who tends to be the primary caregiver in younger children, is willing to do. So, for example, I do all the screening for thyroid disease in my patients. I prescribe their growth hormone. So, in general, while they could see an endocrinologist, most of them want to minimize seeing doctors. So they're more than happy for me to do that. Some nephrologists would prefer the endocrinologist to do that. That's fine. And some families might prefer to be seen by an endocrinologist. Once you start getting into androgens, I'd certainly leave that to the endocrinologist. Many children need to see an orthopedist, and orthopedic issues are fairly common. But again, that tends to be if it's either sort of obvious that there's rickets present, or if specific current concerns develop. You know, having a low threshold for being seen by an orthopedist is reasonable. Everybody needs to see an eye doctor. And, you know, that's one thing that I'm really constantly pushing my patients to do. But those are really some of the, you know, specialists. Obviously, you know, a lot of other things are based on specific needs. What percentage of people with cystinosis need to have a kidney transplant? What is the average age? Okay. You know, in the past, everybody with cystinosis developed kidney failure and needed a kidney transplant. Nowadays, with cysteamine, many patients are going into adulthood without a kidney transplant. And, you know, I even know of patients in their 30s without a kidney transplant. The percentage that make it that far without a transplant currently is pretty low. Obviously, you know, with stem cell therapy, if done early, who knows? Maybe no one will need a kidney transplant eventually. But with current therapy, we think most people will eventually, at some point in their life, need a transplant because the cysteamine is good, but it's not perfect. But again, it can vary. And remember, there's some people that have that juvenile form, that milder form, and they, especially with therapy, are more likely to make it without a transplant. Those with the infantile form, though, it'd be somewhat unusual, although I have patients that are in their early 20s and have very good kidney function. And so I'm hoping that they'll go, you know, a couple more, you know, a decade or two more without needing a transplant, maybe even longer than that. We don't know. What is the average age without therapy? It's about age 10. With therapy, you know, it really varies. It sort of depends on how early the therapy was started, how good people are at taking the therapy. As you know, it's not an easy therapy to take. And so you know, it just varies a lot from patient to patient. Any other questions?
I think you've given out so much great information, and I'm thrilled that Christine, Clinton, and the rest of the CRN team are going to be putting this on the website, because I think you're going to be able to help so many other families who couldn't make it today. So I wanted to thank you for coming. And Christy, Clinton, is there anything else you want to share before I close off our session tonight?
No, just thank you to Dr. Greenbaum. This is really great. And as Carrie mentioned, it's this will be a resource on the CRN website, and we'll be sure to direct our newly diagnosed families to this resource. And we really thank all of you who were able to join us live this evening, and thanks for taking the time.
Thanks so much. Y'all have a good evening.
Wonderful. Well, we look forward to seeing everybody else. We have 2 more sessions that are coming up. One focusing on mental health, which I think is going to be a phenomenal night. And you know, we am just like this, an interactive opportunity for you to get your questions answered, to kind of talk about things that are maybe a little bit more difficult, or you may not have a chance to talk about with other people. And then middle of October, we're going to wrap up this session talking about the future of cystinosis, you know, gene therapy and research. So feel free to email me. Everybody's got my email with these sessions. Feel free to email me if you have any questions, or if you want to submit questions, just like we had some families submit questions. And otherwise, we will see you guys next week. Have a wonderful night, everybody.
Bye, everyone.